Thank you very much, Elijah. As mentioned, I'm here to talk about the familial evaluation after sudden cardiac death, preventing further tragedies. Most of what I'm going to cover is actually revision of things that have already been mentioned, and I'm hopefully going to leave you with key messages to take away from what you've heard today. That is a little bit of background about young sudden death and epidemiology, why it is important to determine the exact underlying cause of death, and give you an illustration of how it is that we do prevent further tragedies in families. So to start with, you've seen some of these numbers already today. Sudden cardiac death in young people, that is individuals under the age of 35, is not very common, but it's sufficiently common that we need to be worried about it. And depending on which data you look at from across Europe, your incidence per 100,000 person years can be anywhere between about 1 and 3 per 100,000. And we know from both US military trainees and from Professor Corrado's data that the risk in those who undergo regular physical training appears to be higher. Of those studies that I've looked at, I'm going to highlight two recent European series. That is a Danish series on the left, a population-based study, and an Irish series on the right, again, a further population-based study. And there are some main messages to take away from this. The first is, as illustrated on the graph on the right, that men, in red, have a higher risk than women, and at least double, perhaps more. The second message to take away from this is, as we have long suspected at CRI, that the most common underlying cause of death in the Danish series on the left is SUD, or sudden unexplained death, and in the Irish series on the right, SADS, or sudden arrhythmic death syndrome. Given their importance, I'll reiterate exactly what it is that we mean by these words. So SADS, or sudden arrhythmic death syndrome, essentially means a premature death that is unexplained. So this is a diagnosis by exclusion. There is an overlap in terminology, particularly with our colleagues overseas who use the term sudden unexplained death, or SUD, sudden unexplained death with negative autopsy, which is fairly consistent with SADS, and sudden unexplained death in the young. These all essentially represent the same group of individuals who have suffered a premature death. So, what does a SADS death represent? We've heard repeatedly through the day, but I will reiterate this. These are all because these individuals have clearly died from something that hasn't been identified at post-mortem examination. Initial work on this has, from Dr. Baer, my supervisor, back in 2003, focused on blood relatives of the SADS victims and found evidence of inherited cardiac conditions, so things like the long QT syndrome, Brugada syndrome, etc., in around about 20% of these individuals. So this was back in 2003 with a relatively limited cardiac evaluation using history examination, ECG, and echocardiogram. Subsequent series up here in 2008, again from Dr. Baer, with a larger cohort and a more comprehensive evaluation strategy, which did include some genetic testing, showed that the yield can be improved to a little over 50% of inherited heart disease. There have been some further series from European colleagues and also a series from Manchester since then showing comparable yields. So having demonstrated that SADS deaths by familial evaluation have, or certainly a proportion of which can have a genetic cause, other groups have gone on to investigate molecular autopsy, which is demonstrated by this graph in the bottom right. And again, apart from the bars coloured in pink, shows a yield of between 5 and about 30% inherited disease determined by molecular genetic analysis after the death of someone who apparently has died for no explicable reason. Remember that those numbers are lower than that in familial evaluation, largely, we suspect, because The molecular basis for all of these inherited conditions, quite simply, has not yet been described. So just to reiterate why it is that we prefer the term sudden arrhythmic death syndrome, if you look at the diagnoses that we're finding in these families, we're talking about inherited conditions that predispose affected individuals to potentially fatal arrhythmias, hence sudden arrhythmic death syndrome, which highlights the fact that you should be consulting a cardiologist about these individuals and their families. Going back to these two European series, the final message to take away, having demonstrated that SUD and SADS, at least a proportion of those deaths are due to inherited heart diseases, I've labelled here all the other causes of death which predominate amongst these young or premature sudden deaths that may also be attributable to inherited or genetic cardiovascular conditions. There may be some argument about some of those which haven't been labelled, which we'll talk about later. So the key here is not just determining what the cause of death is, but identifying and preventing further deaths. We've seen a slide like this earlier today, and our investigation begins with a post-mortem examination. So we're interested in the groups highlighted within the ellipses in the bottom right, that is morphologically normal hearts, so which can be certified at death as unascertained or similar terminology, or those which have a definite cardiac abnormality that predisposes that individual to sudden death. You'll see on this slide that I've put an overlap area or a grey zone. My colleague Dr. Papadakis mentioned this study earlier, but I'd like to reiterate the message that we have learnt from our experience. That is, those individuals who die a premature sudden death, who have cardiac abnormalities on a post-mortem that, in our opinion, were insufficient to be deemed the definite underlying cause, can be investigated and show that inherited disease underlies about a half of those deaths. Dr. Papadakis showed a slide that actually the makeup of these inherited conditions are almost identical to a true SADS cohort, that is, individuals who have no abnormality on their post-mortem. There are two main messages to take away from this. The first is that some certified causes of death may well actually represent an inherited condition, although they appear not to. So, floppy mitral valve or mitral valve prolapse, not commonly regarded as an inherited condition. Coronary artery disease may or may not be regarded as inherited. Myocardial inflammatory infiltrates, if interpreted as myocarditis, would be considered an acquired rather than inherited condition, and yet in about a half of those individuals, their families show evidence of an inherited ion channelopathy, which would only be diagnosed if, firstly, the family are referred for evaluation, and secondly, the individual making that evaluation considers the death with an open mind. Secondly, the other main message from this study is abnormalities that in non-specialist hands may be interpreted as indicative of a cardiomyopathy. So we're talking about things like right ventricular fat infiltration, ventricular dilatation at post-mortem, left ventricular hypertrophy or idiopathic fibrosis, or a combination of both in the absence of myocyte disarray, which would usually be required to make a diagnosis of HCM. These findings can be suggestive, but not definitely diagnostic of a cardiomyopathy. And on evaluating family members of people who died with these findings, again, as with a true SADS cohort, we find a predominance of cardiac ion channel disease, which may be missed unless you're looking for it. Two main messages. Keep an open mind. So what we would say, our takeaway message from this is that if you have an unascertained or SADS death or a death with an apparently definite cardiac cause, whether deemed to be acquired or inherited, all of these postmortems and or reports should be reviewed by a pathologist or a clinician with an interest in inherited heart disease, because it's all in the interpretation, and certainly as a minimum go beyond the death certificate and actually review the postmortem itself. This is the pathway, or a variation of it, that most families will go through following a premature sudden death. And the block to referral, certainly in this country and probably internationally, often happens because the pathologist's responsibility is to the coroner and not to the surviving remaining family members. And so it tends to be at, where I've illustrated with this red line, the block in the referral for individuals. And primary care doctors or general practitioners actually are in a fairly unique position to facilitate this alongside, certainly in this country, cardiac risk in the young, who offer support in such situations. But general practitioners often have clusters of families registered with them, and identifying an individual who has died should automatically prompt referral of other family members, particularly if they are your own patients. The final step in the decision-making process by primary care is where to refer these individuals, and I've put here specialist sudden cardiac death clinic. I'll illustrate why. This is a paper actually from Europe in Denmark that's described as real-world experience of investigating unexplained sudden death or unexplained sudden death survivors. The numbers in each of those boxes probably aren't relevant, but the headline number here is their yield of inherited heart disease was 14% of those families who were investigated. And I've already shown you evidence that even from Dr. Baer's experience back in 2003, we can do better than that. And certainly now, we can do substantially better than that. And the authors of this paper, who I'm sure the medics among you will appreciate, are fairly motivated, given that they went to the trouble of publishing their experience, even they agree that familial evaluation should be performed at regional or national centres of excellence. I can't give you any stronger message than this. This is a variation of a number of different pathways all put together, and part of this is based on our own experience, part of it is based on evidence. But the takeaway message from this is that any either unexplained or clear sudden cardiac death, whether there is a post-mortem, and certainly if there is an incomplete or inconclusive post-mortem, should prompt familial evaluation. This familial evaluation, in almost all cases, should involve a history, examination, ECG, and echocardiogram as baseline. We can debate about what else should be included. But having moved on from there, depending on where your suspicions lie, you may then proceed down any one of a number of different routes to include exercise provocation testing, Holter monitoring to review nocturnal changes, drug provocation testing, cardiac MRI, signal average ECG, and lipid profiles if appropriate. And it's not necessarily that you would only go down one of these pathways. And in fact, in our SADS families, we would go down almost all of them. Because if you don't find an explanation, you look a little bit harder. That is what improves your yield. I've put here on the left-hand side in blue, molecular autopsy when DNA is available. I'm not going to spend a lot of time on this, although it is an interest of mine, because essentially that requires, firstly, DNA to be made available, and as Dr. Shepherd said earlier this morning, this is something that we are working on in this country because it is somewhat difficult. In the presence of a definite inherited cardiac condition found at the time of post-mortem, it has clear clinical value, and our view is that in those unexplained SADS deaths, it also has some merit. Having made your probable or definite diagnosis, you then go on to evaluate the rest of the family in green at the bottom of this slide. Having put that flow chart up, you probably think that the entire clinic revolves around having all the tests available. And that is certainly part of it. And we had a discussion about what constitutes an expert centre earlier this morning. However, the key to these clinics is actually being family-centred. This is a relatively unusual concept for cardiologists and certainly most physicians, and is an idea that has been borrowed from genetics clinics who sensibly realised that all of these conditions revolve around specific families or pedigrees, and so family groups should be evaluated ideally together in a single centre with expertise in cardiology, paediatric cardiology, cardiovascular genetics, cardiac imaging, cardiac electrophysiology, perhaps others. And this allows a coordinated review of investigations, specifically in those families where there may be multiple equivocal tests which, when reviewed together, give you a probable or definite diagnosis. And it also allows families to be given advice to both affected and unaffected individuals in a coordinated effort. So, in those individuals where we've made a diagnosis, how do we prevent further deaths? We've already had talks earlier today about specific conditions that can underlie these premature sudden deaths, and I'm going to talk a little bit more about this. The first thing is familial expectations. Some individuals often come to these clinics where their primary request is to find an answer, particularly in those SADS deaths where they are left with uncertainty and no explanation. And certainly giving an answer may actually be the point at which your patient or your family then almost stop listening to you. But it is important to remember that that's not the end of our role as physicians. Before I go on to talk about how we manage individuals, it's important that actually, once you've made a diagnosis, this should then automatically precipitate another cascade, okay? So the same circle of familial evaluation, genetic testing, identifies others at risk. So you've identified one affected individual, which, unfortunately for them, made the diagnosis, but then also gave them a diagnosis for their relative who died. And also, I should reiterate that age-dependent penetrance is well recognized in a number of these conditions, particularly in the inherited cardiomyopathies, and serial evaluation is warranted perhaps every 2 to 5 years in most cardiomyopathic processes. As an example, given we've not had talks about the long QT syndrome, I'm just going to mention risk stratification. We've already talked about those features which predispose individuals to a risk of sudden death in Brugada syndrome, hypertrophic cardiomyopathy, and ARVC. In long QT syndrome, QT interval, gender, symptoms, particularly arrhythmic symptoms, and mutation-specific risk have all been looked at, along with a number of other electrocardiographic and echocardiographic markers which are perhaps less proven. But almost universally in all of these conditions, arrhythmic symptoms, particularly in the despite medical therapy, always predisposes to higher risk. But we can do something about this to prevent further tragedies. And in a number of conditions and for a number of individuals, lifestyle modification may be sufficient. So in the long QT syndrome, the medical website qtdrugs.org has a list of substances to avoid in these individuals, or the CRY website has a suitable list for family members to look at. Electrolyte imbalance should be watched for. Competitive or endurance sports should be avoided. Medical therapy is available for long QT, so things like beta blockade, mixilotine in specific long QT syndromes, and potassium with spironolactone can also be effective. Surgical therapy is available but rarely used. And as everyone knows, we do have device therapy, specifically the implantable cardioverter defibrillator in those individuals who are deemed highest risk, which we had a discussion about earlier. Just to show you that this is not just an academic exercise. This is actually a published series from our counterparts in Manchester who saw about 200 relatives of young sudden death victims, and about a quarter of the individuals referred to their clinic received a diagnosis with, and obviously subsequent lifestyle modification to reduce their risk. About 1 in 10 received medical therapy to reduce their risk of sudden death, and 3% received device therapy. One of the questions that is often difficult to answer is, what do we do about children? I've alluded to the issue of age-related penetrance, but also some of these investigations can be a little bit difficult for children to deal with. Well, our counterparts in Europe have actually written, albeit a relatively small series of just 36 families, where they were referred purely paediatric, so children who are relatives of sudden death victims or aborted sudden death victims. And similar to adult populations, about a quarter received risk modification following their diagnosis. 16% received device therapy, and most compellingly, actually in their series, with just like a 4-year follow-up, 7% received appropriate defibrillator shocks. And while not all of those would necessarily equate to sudden death, if we assume that at least a half of those would have done, that's fairly compelling evidence to investigate paediatric family members as well as adult family members. To summarize some of the take-home messages, young sudden cardiac death is frequently due to an inherited heart condition. Keep an open mind when reviewing your post-mortem reports, and go beyond the death certificate when reviewing a family with a premature sudden death. First-degree blood relatives should all be referred for evaluation, preferably in a regional or national centre of excellence with a family unit-centred clinic. And making a diagnosis, while it is made at the expense of identifying a surviving member at risk, it does at least allow their risk to be modified. And obviously the aim of all of this is prevention of further tragedies. Thank you very much for your attention.